Hello everybody, thank you for joining us. It's a delight to be here with you. I'm talking about NAFLD today, which follows on nicely from what Amanda spoke about with metabolic syndrome. Now, as she pointed out in her presentation, 66% of adults in the United States are overweight and 42% are obese. Now, obesity is a serious and costly health issue, but it becomes even more costly if those individuals go on to develop NAFLD, and it is exactly those individuals who are most at risk. And concerningly, NAFLD can progress to serious life-threatening conditions. It's also a major driver of cardiovascular disease, the #1 cause of death in the United States. Now, NAFLD is like a stealth weapon. There's no overt symptoms until it's fairly progressed. It's a complex, multi-organ condition, and as such, it needs a fully considered treatment approach. So when we're formulating a treatment plan for our patients, we need to understand the clinical presentation, the health history, and the associated risk factors for each individual patient. This may sound somewhat daunting and complex. However, by the end of this presentation, you'll have highly effective, simple clinical strategies to address the magnitude of issues that we see in NAFLD, and you'll have treatment protocols that you can start using immediately to get the clinical outcomes you desire in your patients. So let's get started. The topics I'm covering today. First of all, I'm going to start with just looking at what is the NAFLD metabolic syndrome connection, and this will just tie it together with what Amanda's already spoken about. Then we'll look at what is NAFLD, non-alcoholic fatty liver disease. What is it, and what's the prevalence of it? And as with metabolic syndrome, you'll see it's probably a lot higher than you might imagine. We'll review the latest information on the pathogenesis. And if we can understand this as practitioners, there's a lot of keys within this to help us treat our patients effectively. We'll look at the causes and consequences. Again, if we can understand these, particularly the causes for each individual patient, then it gives us a lot of information about how we can treat that patient. We'll look at how we can diagnose it, and we'll look at the treatment. We'll start with allopathic treatment. How is it treated in allopathic medicine? Then we'll look at lifestyle and diet. We'll look at exercise, and importantly, we'll look at the key herbs. And the information I'm giving you is based on clinical research, but also on my clinical experience. And we'll finish with a case from my clinic. So NAFLD is often described as the hepatic manifestation of metabolic syndrome, but that's way too simplistic. It's much more complex than that. It can be both a consequence of metabolic syndrome or a precursor, so a consequence or a risk factor. So it's actually a bidirectional relationship, and you'll see this when I show you later all the risk factors and consequences. You will see there that many of them are bidirectional. And when we see our patients, and they might have metabolic syndrome and they may have NAFLD, we don't really know which ones come first, and it doesn't matter. We have to deal with both of them, and you'll find out how we can do that throughout this presentation. There's no doubt that obese people and those with type 2 diabetes are at greatest risk of developing NAFLD. The prevalence of obesity in NAFLD patients is up to 90%. Of diabetes, it's up to about 70%. But what's the role of NAFLD in the development of metabolic syndrome and type 2 diabetes? Well, NAFLD can actually set up multiple sites of metabolic dysregulation. First of all, with the hepatic steatosis, that fatty liver. It can cause cardiometabolic risk factors, and it can upset glycemic control. And all of this can go on to lead to metabolic syndrome and type 2 diabetes. And as I alluded to in my introduction, it's like a stealth weapon. This pathway is asymptomatic, so patients don't know that it's happening. And it's our job as clinicians to be keeping an eye out for these things. And certainly if you have a patient who is obese, you have to be assessing them for NAFLD. But even if we have patients who are overweight, particularly if their weight continues to climb, and this can happen very slowly over time, we need to be alerting them to the dangers that lay ahead with metabolic syndrome, with NAFLD. And we need to be continually assessing them for these conditions. Not everybody with NAFLD is overweight. We can have something that's called lean NAFLD. So these are people who are normal weight, but they will have the visceral adiposity and they can have insulin resistance. They're sometimes referred to as a metabolically obese but normal weight patient. I think lean NAFLD is much easier. And up to 20% of NAFLD patients can fit into this category. And it's very easy when we see patients in our clinic who are normal weight and sometimes very slim to disregard the possibility of metabolic syndrome or NAFLD, or in the case of reproductive disorders, to disregard PCOS. But we really have to be very careful about that because it can exist. And one of the major drivers of lean NAFLD is a high fructose diet. Another major driver is stress. And I'll just show you this diagram here, and it shows you lean and overweight individuals, in this case women, and you'll see on A and C are just no central body adiposity, and B and D show that central body adiposity. And you can see in the diagram B, you can see that woman, she's not overweight at all, she's quite lean, but she's got that podgy little tummy, she's got that central body adiposity. And we can easily miss this in our clinics. Sometimes I'll say to women, lift up your shirt, I want to see your tummy, because it's really important that we know that, and it's easily missed. Now, one of the things that they found in research is that and the research has been done in women, so I'll talk about women, but it probably equally applies to men. What they found is in lean women who have that central body adiposity, and it's not very much, but when they lay down fat, that's where it goes. They have an altered HPA axis. They have a dysfunctional HPA axis. They have high levels of cortisol, and it's a cortisol that's actually responsible for that central body adiposity. So when you have this woman sitting opposite you in your clinic, she's lean with central body adiposity, the first thing you have to think about is supporting the HPA axis, because she will probably have elevated cortisol. Of course, we need to go deeper than that. What's causing all this? Often it's disruption of gut microbiome. You know, we have to keep digging deeper, but we have to think about this. It's very easy to miss these patients. As we can see, 20% of them could have NAFLD, and we might totally miss it. So NAFLD is a leading cause of liver disease in developed countries. It's a metabolic disease with extensive organ involvement. It can progress to non-alcoholic steatosis or NASH, cirrhosis, hepatocellular carcinoma, and of course there's fibrosis mixed in there as well. So what's happening here? We first of all have the lipid accumulation around the liver, and then we see the lipotoxicity associated with that. We get high levels of oxidative stress, we get mitochondrial dysfunction, leading to hepatocyte death, inflammation, and the fibrosis. 74% of triglycerides in NAFLD patients come from the diet, 26% from hepatic de novo lipogenesis, so fat that's actually made in the liver. NAFLD is one of the main diseases that lead to hepatic insufficiency, hepatocellular carcinoma, liver-related mortality, and the need for liver transplantation. It also is a major cause of overall mortality. And in fact, the majority of people who die from NAFLD actually die from cardiovascular disease, which is a consequence of the NAFLD. And it's the most common cause of abnormal liver function tests in children. Now, Amanda spoke about obesity in children, and we're seeing increasing levels of NAFLD in children as well because of the increasing obesity. And there was a time, not that long ago, when we all thought of NAFLD and metabolic syndrome, type 2 diabetes as adult conditions. That's not the case any longer. And it's due to this rising incidence of obesity in children, which is largely due to the lives that we lead and the lifestyles and diets that we have and lack of exercise. So what's the definition of NAFLD? It's defined as hepatic fat accumulation of more than 5% after we exclude from other causes. So causes like excessive alcohol consumption, hepatitis C, autoimmune hepatitis, and so on. Now, I'd like to just speak for a moment about excessive alcohol consumption because I think it is a huge problem with our patients. We might say to our patients, how much do you drink? And they might say, oh, you know, I have 1, maybe 2 glasses of wine each evening to wind down, maybe on weekends a little bit more. But what we really actually want to be knowing is how much is in the glass. You know, like a glass of wine is not usually 5 ounces. And if you look at what is a standard drink in the United States containing 14 grams of alcohol, it's 5 ounces. I've been to the US on a lot of occasions and I've never had a glass of wine as small as 5 ounces. So the excessive alcohol consumption is defined as more than 20 grams of alcohol for women or more than 30 grams of alcohol for men. So that means that if you're having a 5-ounce glass of wine, assuming it's only 12% alcohol, women could maybe have 1.5 glasses, men could have 2 glasses. Now, I think that the majority of people we see in our clinics, when they say they've had a glass of wine, it's going to be a lot larger than that 5 ounces. So what I do in my clinic is I get a wine glass and I measure 100 ml of water. In Australia, it's 100 ml. I measure that into the wine glass and I just say, do you drink more than this? And they're all going to say, yes, we do. It's probably twice that amount per drink. So it's a big problem that often goes unnoticed. And it's very easy to kid yourself that you're not drinking very much alcohol. So NAFLD includes a wide spectrum of conditions, starting from benign fat deposits with no inflammation at all and not really causing any damage, right through to the fibrosis, the cirrhosis, hepatocellular carcinoma. Now, many say it's time for a name change with NAFLD. Last year, a panel of 22 international experts got together and they really wanted to integrate all the current understanding we have about this condition, the condition we call NAFLD. And they felt that the term NAFLD doesn't actually reflect the current knowledge that we have. So they've proposed a new term, Metabolic Associated Fatty Liver Disease, or MAFLD. And they felt it was a much more appropriate, overreaching term to use. And already, researchers are starting to use this definition in research. And a paper published just this year, researchers are saying that this new definition, which I'll show you in a moment, actually helps to deconvolute the disease heterogeneity, and it really simplifies diagnosis and therefore treatment. And that simplicity helps to suit all healthcare systems, whether they're in rich countries or developing countries that have very little money for healthcare. So what is the definition of MAFLD? There has to be the presence of hepatic steatosis. The most common way that will be diagnosed is on ultrasound. Plus, there has to be one of 3 of the following metabolic criteria. Patient has to be overweight or obese. They have to have metabolic dysregulation or type 2 diabetes, any one of those. So what is metabolic dysregulation? How is it defined in this context? Well, this is the definition that they've come up with. Now you'll see everything in the white font there is pretty much what Amanda's given you for the definition of metabolic syndrome. With the exception, they haven't got elevated blood glucose here, but that's pretty much what pre-diabetes is. So in the definition of metabolic syndrome, it's any 3 of the following. In this definition, they've chosen to say any 2 of the following. So in addition to what Amanda's already given you for metabolic syndrome, there's also the HOMA-IR score and the high sensitivity CRP, which is looked at as well. And look, really, in my clinical experience, most patients are going to have more than 2 of these, really. So it's not that hard to diagnose when you've got this sort of criteria. And when we use this, rather than just the presence of fatty liver, then it means that we've automatically ruled out some of those other causes of fatty liver. I mentioned that NAFLD can progress to more serious conditions, and here's a diagram that shows you that. So you can see we can start with a healthy liver, and then we're going to get that benign fatty liver. We get that lipogenesis, we get the lipotoxicity, etc., and we have NAFLD. We get increasing inflammation and oxidative damage that can lead to the NASH. And that will happen in up to 30% of people. In up to 20% of people, that will go on to develop into cirrhosis and then possibly into hepatocellular carcinoma. And you can see here that that cirrhosis step can be bypassed, and some people will go straight from NASH to hepatocellular carcinoma. So don't think, well, the patient hasn't got cirrhosis yet, so we've got time. It's a very silly approach, and I've heard practitioners talking about that. And what's really interesting with this diagram is you can see that up to the point where a patient goes from NASH to cirrhosis or NASH to HCC, it's reversible. You can see those 2-way arrows. So that's, if we can get the patient at that point, we can totally reverse this. And I've seen that countless times in my clinic. What's the prevalence of NAFLD? As I said, you'll be surprised at how high it is. If we look at the global prevalence, it's about 25 to 30%, but there's a very wide geographical variation. In the United States, it's about 21 to 25%. That is around 64 million people. Quite astounding. The American Liver Foundation in 2017 estimated that it could be as high as 30% and 100 million individuals. So there's a lot of people there that desperately need our help. The risk increases with age, as does the progression to more dangerous conditions, particularly in those over 50. So I think we're all seeing an aging population in our clinics, more and more people over the age of 50, and we need to keep this in mind when we're dealing with them. And it's very common, particularly in women, to put on a little bit of extra weight in those perimenopausal and postmenopausal years. So we need to be thinking the whole time, what are their parameters? We need to be testing them. We need to make sure that they keep their waist-hip ratio healthy, they keep their BMI healthy. And if we can get onto that really early and keep reminding them and encouraging them, it's not going to be a big job for them. They can do it pretty easily when it's just going up by small amounts. And unfortunately, there's an increasing incidence in children and adolescents. And this next slide I'm going to show you was a study where they looked at 14 countries, and by using the fatty liver index, which I'll show you in a moment, they determined that across those 14 countries, about 33% of adults had NAFLD, which is astounding, but we know there's wide variation. Now, they then gave the information from 6 countries. And the reason I'm giving this to you is to show you the incidence in children. So ultrasound was used in most, in some places, liver enzymes, and the histology would have been a biopsy. So you can see children in Germany, 2% might have NAFLD, but if we look at obese children, it's 36%. That's astounding. These children do not have good health outcomes later in life. unless we can get on top of that. Obese children in Italy, 44% will have NAFLD. And this also gives the figures for adolescents. But I think if we looked at obese individuals, that figure would be much higher. And this diagram or this table also gives us the number, the percentages for diabetic patients. And you can see that the percentage of NAFLD in diabetic patients is much more than other populations. So for a moment, I'd just like to go through NAFLD in children. How is it happening? Why is it happening? We know that early life factors can be associated, we've known for a long time, can be associated with obesity later in life, with altered gut microbiome, altered HPA axis. We now know they also increase the risk of NAFLD. So this is stressful events that can happen either in utero or in those first 2 or 3 years of life. There's been an ongoing study done in Australia. It's called the RAIN study, and it's carried out in Perth in Western Australia, where Angela comes from. Between 1989 and 1991, they enrolled almost 3,000 pregnant women. They were all at least 18 weeks gestation at the time of enrolment. And at the time that this data was collated, they'd been studying the children of those women for 27 years, almost 3,000 children. And they looked at them at birth and then followed them every few years. So what have they found? They found that after they adjust for adult obesity, maternal pre-pregnancy diabetes, and a gestational weight gain of more than 13 pounds by week 18 were independent risk factors for NAFLD in adolescent girls. So when we're dealing with pregnant women, we need to keep this in mind. And interestingly, I don't quite understand this, but they found that lower socioeconomic status at birth was the only independent predictor in adolescent boys. So that's interesting. And it'll be interesting to see as they release more data over the lives of these children, now adults, whether that changes in the men. So I've put this diagram in because it just shows us the prenatal, gestational diabetes, gestational obesity, but a high-fat diet during pregnancy. The infant can actually be born with fat deposits on the liver and in the intra-abdominal cavity. They're starting off at a low base. And then we can see the postnatal impacts as well. If we look at the prevalence of some of the comorbidities like metabolic syndrome, etc., it gives us, we've already looked at how much NAFLD is in those patients, but now we're going to look at how much of those conditions we will see in NAFLD. And this was a study that looked at nearly 9 million people over 86 studies from 22 countries. And you can see the percentages here. Of the NAFLD patients, 51% were obese, 42.5% had metabolic syndrome, etc. Nearly 41% were progressing or had progressed to fibrosis. Now, this is again over 22 countries, and we know there's a really wide geographical variation. So I'm going to show you this fantastic obesity map that Amanda showed you earlier today, because what this highlights is the differences in prevalence of obesity in different areas of the United States. So this is also going to give you an indication as to the prevalence of NAFLD. So if you're in one of those very dark red maroon states, you will be seeing higher levels of obesity, you will be seeing higher levels of type 2 diabetes, and you will be seeing higher levels of NAFLD than what you would be seeing, for example, if you lived in California. Now, we also have to consider it may depend where do you practice within that state. And we know that you can get huge variations within a state, even within a city, as to the incidence of some of these conditions. NAFLD is a major driver of cardiovascular disease, and it's an independent risk factor irrespective of any metabolic disorders. We see an increase in atherosclerosis, cardiomyopathy, and arrhythmia. And these cardiovascular changes are due to systemic inflammation and oxidative stress, endothelial dysfunction, and the hepatic insulin resistance and altered lipid metabolism that we see. And it is strongly associated with hypertension, which we know is the most important and the most dangerous risk factor for cardiovascular disease. So now we'll move on to the pathogenesis of NAFLD. And as I said earlier, if we can understand this, we're much better aimed to treat our patients effectively. Back in 1998, the pathogenesis was described as a tale of two hits, fairly simplistic. The first hit was that fat accumulation in the liver, and then the second hit could be some other insult. It could be dysbiosis and bacterial translocation. In many cases, it's going to be oxidative stress, or at least oxidative stress will be playing a role. We have the development of NAFLD. But since 1998, we've learned a lot about NAFLD, and now we have what's called the multi-hit hypothesis, which of course is much more accurate. And this is where they believe that multiple factors act in parallel and synergistically to cause NAFLD. And these can include, but not limited to, the disruption of regulation of pathways in the pancreas, the gut, the immune system, adipose tissue, etc. And, you know, there's way more beyond that. So there's a lot of different things potentially going on in a patient who has developed NAFLD. And it's our job as clinicians to actually sort out for each individual patient what are the factors we need to address in that patient. Now, this diagram's fairly busy, but I like it because it gives us a lot of information in one place. And you can see there that it starts with looking at diet. And usually they're talking about a high-fat, high-carbohydrate diet, in this case high fructose as well. And when you combine that with a sedentary lifestyle, which many of our patients will have, we get an energy excess. In other words, we're storing a lot of that energy as fat because it's not being used. That's when we can start getting those benign fatty deposits on the liver. We can end up with obesity, gut dysbiosis, which will always cause leaky gut, causing endotoxin into the systemic circulation. We have insulin resistance, oxidative stress, low-grade chronic inflammation, and that can go on to lead to NAFLD. We can also have high iron stores, which can cause hypoxia, increase oxidative stress. And you'll see on the cause and consequences slides I'll show you later that high iron is a big risk factor. Of course, there's genetic and epigenetic factors that come into play as well. There's also gender differences and ethnic differences. But this gives us a really good starting point because it just on the first half of that diagram, we've got half our patients or more actually covered by that. They're going to fit into those categories. Oxidative stress is considered to be the major driver of liver injury and progression to disease. So we have to get on top of that. And of course, we have lots of fantastic herbs that can do that. We see an overproduction of reactive oxygen species, so free radicals, and a shortage of endogenous antioxidant molecules. Our bodies are very, very well designed. We produce a wide range of endogenous antioxidant molecules because with normal metabolism, we're creating oxidative stress. The body is well designed to deal with that. It's not necessarily well designed to deal with very high levels of oxidative stress that our modern lifestyles keep heaping on it. What's the best way to increase antioxidant molecules, endogenous ones? Support NRF2, Amanda's talked about it, and I'll give you the herbs that do that shortly. Lipopolysaccharide is a significant promoter of oxidative stress. Where do we get lipopolysaccharide? Endotoxin leaking from the gut. It causes systemic inflammation and oxidative stress, and it does that because it activates the innate immune system. Lipopolysaccharide should be contained in the gut, but when it gets to high levels, it causes gut inflammation, leaky gut, and it escapes into the systemic circulation. And quite rightly, it activates the innate immune system via the toll-like receptors, particularly toll-like receptor 4 and 9. So we can also work on modulating the innate immune system in this scenario with herbs like echinacea. So now I'm going to show you 2 slides which summarise the causes and consequences. And I've put it in a table form so that it's easy for you to understand. But I have actually read countless research papers to get this information. So you can see here we have risk factors and we have consequences. And for some of them, you can see that they're both. So we have that bidirectional relationship. So things like metabolic dysfunction, for example, inflammation and oxidative stress, lower gut dysbiosis can be a cause of NAFLD, but NAFLD can also cause dysbiosis. I will be talking a little bit more about the lower gut dysbiosis and how it impacts on NAFLD, and I'm going to talk about the circadian clocks. Amanda's talked about it, but I'm just going to talk about it from the point of view of NAFLD. Another list, you can see high iron deposit. It's bidirectional. So when we have these bidirectional relationships, as I said before, we're not going to know which one comes first, and we don't need to know at that point. But what we do need to understand is if somebody's got high iron and they've got NAFLD, the high iron's going to be making the NAFLD worse, and the NAFLD's going to be making the high iron worse. And that's the same for all of these where we see that they're both risk factors and consequences. So we have to get on top of both of them as quickly as we can. Just a couple of things that I want to highlight here, and I'm not going to be talking about them in detail, is periodontitis, because periodontitis is very, very common in our patients, and often they don't know they have it. If they don't go to the dentist regularly for checkups or to get their teeth cleaned, they may not know they have periodontitis. And we know that going to the dentist is quite expensive, and some people simply can't afford it. Some people have real phobias about the dentist and don't go. The easiest way to determine is ask them, do your gums bleed when you brush your teeth? If they do, they're going to have periodontitis. And sarcopenia, we're seeing an increase in our aged patients. We're seeing more elderly patients in our clinic. And we know that as we age, we lose muscle mass, and it's very difficult to gain it. And I've listed there the reasons why muscle mass is so important. So what we need to do with our patients as we see them over the years is keep encouraging them to be doing resistance exercises so that they keep that muscle mass up. Because it's not only with these conditions that sarcopenia has an impact, it has a large impact on everything, including just stability and balance. So people are going to fall over much easier when they have sarcopenia. So it's a very important issue. And to have muscle mass, we need to have adequate protein. A lot of older people don't have enough protein. We need to make sure they do. And as we age, we need to increase our protein intake compared to when we were a bit younger. So how does dysbiosis play a role? There's lots of different pathways that connect the gut microbiome with the pathophysiology of NAFLD. And dysbiosis plays a role also in the progression of NAFLD to NASH. So we start off with dysbiosis, and then we get leaky gut, we get the bacterial translocation, particularly of lipopolysaccharide. That triggers the inflammatory pathways, the oxidative stress, which leads to the fibrosis and cirrhosis. And what they found, at least in one study, is that patients with NASH also had SIBO, or small intestinal bacterial overgrowth. They also had increased circulating endotoxin. So, you know, every time I talk about anything when I'm teaching is you have to keep going back to the gut. What is happening in the gut? We have to always go back to that. And this next diagram just gives us more information about dysbiosis. Here, they use a high-fat, high fructose diet. A lot of studies use a high-fat diet for dysbiosis, and it just highlights some information about the LPS, and I've added a little bit more there, and also with the innate immune system and the toll-like receptors. I won't read that, but you can read that. And you can download this paper yourself and have a look at it. There's a lot of good information there. And this next diagram, this is something I give to my patients now, and because I think it's very, very simplistic. And often when we're telling our patients, look, we need to work on your gut health, and they're saying, well, why? There's nothing wrong with my gut. I've come here because I've got, you know, liver problems, or I've got joint pain or something. So a diagram like this shows how the gut's connected to liver disease, neurodegenerative disorders, cardiovascular disease, etc. So it's a just really simple diagram to show them. And if they want to, they can go and download that paper and have a look at it themselves. Amanda's talked about circadian disruption, and I'll just talk about it in the context of NAFLD. So disruption between the central and the peripheral circadian rhythms is a core feature in almost every genetic, dietary and environmental model of metabolic syndrome and NAFLD. The disruption in the functioning of the peripheral clock regulator pathways is often seen in NAFLD. And this relationship, again, is bidirectional. So if you've got NAFLD and you're not sleeping well, one thing's going to be making the other worse. And we have to start with getting the patient sleeping well. And as Amanda said, it's relatively easy to do. This diagram shows us a coordinated regulation of metabolic physiology by the central and peripheral clock. So we don't just have the circadian clock in the hypothalamus, we have clocks right throughout the body. And you can see here in the gut, the liver, the pancreas, and so on. And the central clock, which of course is driven by light and dark, it doesn't only govern our feeding and fasting cycles and our sleep and resting and activity cycles, it also synchronizes the peripheral clocks. So if you're not sleeping well and you've messed up your central circadian clock, then all these other clocks in the body are going to be disrupted as well. And this actually helps us understand why not sleeping well can have such a big impact on so many diseases. And this is one of the reasons, there's probably many more, but in not sleeping well, in not getting enough sleep, we're actually messing up the circadian clocks in other areas of the body. Sleep disturbance and NAFLD. This was a systemic review meta-analysis of 7 studies, and they found that insomnia and excessive daytime sleepiness increased the risk of NAFLD. That's more than half my patients that I see will report this daytime sleepiness. Another study published in 2015, they found that shortened sleep duration, delayed sleep onset, poor sleep quality, daytime sleepiness were all linked to disease severity. And we also saw, as Amanda talked about, the increase of food intake shifting towards the evening, and sometimes even patients getting up in the night and eating when they can't sleep. And I have a patient who does that, and we have a huge amount of trouble shifting that central body adiposity because she's not sleeping well and she's eating at midnight, 1 o'clock in the morning. Obstructive sleep apnea. It's an independent risk factor associated with the development and progression of NAFLD, and it can often go unknown as well. So I'm sending more and more of my patients to have sleep tests, and you can do them at home these days. You don't need to go to a clinic and sleep somewhere else overnight. There's also an association between obstructive sleep apnea and hypertension. So as Amanda pointed out, in primary hypertension, about 35% of those patients will have obstructive sleep apnea. But when we look at drug-resistant hypertension, that percentage can go up to 80%. So if you have patients that come to you and they say, look, I've got hypertension and I'm now on 3 different drugs, but it's still not coming down, we need to think, well, maybe you need to get tested for sleep apnea if that hasn't already been done. And what we need to do in that case is treat the sleep apnea, not add another antihypertensive drug or keep increasing the dose. But we can go a layer deeper here because we know that gut dysbiosis is a really important factor in the pathophysiology of this OSA-induced hypertension. So we need to deal with the OSA, but we also need to go back and look at the gut microbiome. And what's the easiest way to deal with both of these is good diet and weight loss. In most cases, that's all you need to do to treat OSA. There are other causes sometimes, but in most patients, it's going to be increased weight gain, particularly the fat around the neck. And that's particularly the case with men. So how is NAFLD diagnosed? Biopsy is a gold standard, and you need about 5% of hepatocytes to have that be infiltrated by fat, and hence the definition, more than 5% of fat infiltration. But of course, with biopsies, there's risks. There's complications, you can have bleeding, but there's also only a very small specimen taken, of course, and so it doesn't represent the entire liver. And there is a possibility of variation between pathologists and how they look at that biopsy. So you might have a biopsy that comes back and says you don't have fatty liver, but that may not be the case. So even if you have a biopsy, I think you need to be doing some of these other things. Ultrasound is what's normally used to determine fatty liver. You do need 10% fat infiltration in order to be diagnosed on ultrasound, but it's readily available and it's non-invasive, and it's what's most commonly used to diagnose fatty liver. You can use MRI as well, and it's more definitive, but it's not as available and more expensive. You can do it with CT scan, but of course CT scans subject us to a huge amount of radiation, which is best avoided wherever possible. Elastography is a type of ultrasound that evaluates fibrosis. So if you think the patient may have fibrosis, then this is what you would be requesting. And then there's a range of algorithms that we can use as well. The fatty liver index, which I'll show you on the next slide, the NAFLD fibrosis score, the fibrosis 4 score, etc., to determine if there's fibrosis present. And there's a lot more information in the appendix. Biopsy is necessary to distinguish between NAFLD and NASH. So the fatty liver index, this is in kilos and centimetres. In you can go to this website that I've referenced and you'll get this calculator. I couldn't find one actually that was in pounds. So if you use this, just change the kilos to pounds, and you can change the centimetres in the drop-down box to inches. But all you need really to calculate this is the BMI, the weight circumference, the serum triglycerides, and the GGT, and then you'll get a score. So anything below 30 means that you can rule out fatty liver. At this stage, it doesn't mean we can be complacent. If the patient's obese or even just overweight, we need to consider they will probably develop it at some point. A score between 30 and 60 is inconclusive, and when we look at these algorithms, there's always an inconclusive zone where they don't really know. Maybe there's fibrosis or fatty liver, depending on what you're testing for, and maybe there's not. I always assume that maybe there is and treat accordingly. And of course, over 50 means that fatty liver is present. There's a whole range of blood tests that we can do, and I haven't gone into them here, but when I show you the case history, you'll see the sorts of blood tests that my patient had done. NAFLD, because it's complex, because NASH is very complex, there's actually no single marker that we can use. There's no single marker that will predict the clinical outcome or how people are going to respond to treatments. And interestingly, most of the studies done looking at the biomarkers that are regularly used have been done in patients who are undergoing or have undergone bariatric surgery. That's by far the minority of our patients. So researchers are saying we actually need different cohorts of patients from different ethnicities, but also different starting points and outcomes to determine really what's happening in the real world. Some of the things that are looked at in research, and I do test for some of these in my clinic, the changes in adipokines, oxidative stress, increased inflammatory markers, and I always test for high sensitivity CRP, and I put it in square brackets there because that wasn't mentioned in the research paper, but that's what I test for. I don't usually test for TNF-alpha or different interleukins. I always test for iron. I always do full iron studies to test for ferritin as well. There's limitations here though, because if you did test for all of these, they're all elevated, it doesn't mean the patient has NAFLD. It could mean they've got metabolic syndrome or insulin resistance. So how do we treat NAFLD? First of all, we'll look at the objectives. If we're treating someone, we need to determine in our mind, what are the aims of the treatment? What do we want to achieve? What targets do we have to look at? So we absolutely have to encourage weight loss, healthy diet, exercise, etc. That's a no-brainer. We start there. We have to manage metabolic syndrome and type 2 diabetes if it's present. Amanda's talked about that. Professor Bone will talk about that tomorrow when he's talking about type 2 diabetes. We need to manage all the known risk factors and manage the known consequences. And of course, you've got those on those tables on slides 25 and 26. But we particularly have to be thinking about dysbiosis and sleep disturbance. And I've put periodontitis here just to remind us to be checking our patients for that. Because as I said, it's often overlooked. Patients don't even know they have it until it's very advanced and they have to go and have it seen to. And of course, we have to support overall liver health. And for me, it's milk thistle. You have to be using milk thistle in any liver disorder at all. And we'll look at that when we look at the different herbs. Allopathic treatment. There's lots of clinical trials showing promising results for some drugs in NAFLD and NASH, but nothing has been approved. So there's no drug that patients can go and get to deal directly with their NAFLD. So the gold standard allopathically is lifestyle changes, diet, weight loss, exercise. And the allopathic method says, or the allopathic approach says that this is the only effective way to treat NAFLD. Well, of course, we know it's not because we have herbs and nutrients that can help. But of course, we also have to do these lifestyle changes as well. Now, when you see patients with NAFLD, they may well come in and say, oh, I've got these drugs for my NAFLD. Well, let's have a look at what some of those drugs might be. The first four on here are going to be for the metabolic dysregulation they have that's either brought about the NAFLD or vice versa. This one is to regulate the composition of bile, because we know that dysregulated bile can be a cause of NAFLD. So we can use herbs to make sure that the bile constituents are well balanced. And then, of course, the last two are for cardiovascular risk factors. In the research, there's some nutrients and there's milk thistle, most commonly talking about vitamin E, and they found that some studies, vitamin E will improve NAFLD, partly because it's an antioxidant, but may well be because patients are deficient in it. And there's been some good studies for vitamin C as well. Low vitamin D is a risk factor for NAFLD, so we always need to be checking that. And of course, as I said, silymarin is really the liver herb. You combine it with other liver herbs depending on what you're wanting to achieve, but I think it always has to be one of the herbs you use for liver conditions. So what are the lifestyle factors we need to consider? The Mediterranean diet. It just keeps coming up in all chronic diseases, really, particularly when they're to do with metabolic dysregulation and obesity. And in the handout, you'll see the pyramid that Amanda's put together showing the modified Mediterranean diet. And I suggest that's what you use in your patients. It's what I use in my patients. So this was a clinical study where they used a Mediterranean diet and they had moderate fat, restricted calories, high vegetables, low red meat. They replaced some of the red meat with poultry and fish. 15,000 kilocalories for women, 18 for men. And they found that patients who lost more than 5% body weight had a significant regression of the fibrosis, which is a really important point, and improvement in glycemic profile, improved A1C, but also improved ALT and fibrosis score. So this tells us that this sort of dietary approach is not only good for weight loss and blood sugar issues, it's also good for NAFLD. And we have the portfolio diet. We've known for a long time that the portfolio diet can lower cholesterol, but it also is very beneficial in NAFLD. We see a reduction in LDL, the LDL cholesterol, triglycerides, apolipoprotein B, blood pressure, CRP, etc., and an improved 10-year cardiovascular disease risk. So that's significant. So what is the portfolio diet? There's 4 key food components: nuts, protein from vegetable sources, from pulses like peas, beans, lentils, chickpeas, etc., fibre from vegetables again and fruits, and plant sterols. Now the levels there in ounces that I've given you, that's the amount that's used in a 2,000 kilocal diet per day diet. So you may want to decrease those if the diet has lower calories in it, but really just make these a bigger part of the diet, I think. And so what I tell patients to do is incorporate the portfolio diet into the Mediterranean diet. And when you look at this, high in pulses, high in nuts, high in fruit and vegetables, that's what the Mediterranean diet is anyway, the traditional Mediterranean diet. It was very low in red meat because it was really a peasant diet. They couldn't afford a lot of meat. They only had it when they had it themselves to kill and eat. It was mostly a plant-based diet. How does exercise help NAFLD? Well, there's no doubt that it does improve NAFLD. Of course, it reduces insulin resistance, it improves NASH. So in the liver, what is exercise really doing? It's increasing fatty acid oxidation in the liver. It's decreasing the fatty acid synthesis of that hepatic de novo lipogenesis that I talked about. It's preventing the mitochondrial dysfunction, the damage to the hepatocytes. Because it's reducing the damage, it's reducing the release of damage-associated molecular patterns, DAMPs, which then activate the innate immune system via the toll-like receptors. So it keeps coming back to inflammation and the innate immune system and oxidative stress. Now, interestingly, it appears that there's no significant evidence to show that one regime should be recommended over another. And I think this is really good news because if you look at all your patients and even yourself, there's some sorts of exercises we like to do, some that we don't like to do so much. So, it gives us wider scope to work with what suits our patients and what they can manage. So they did, high intensity interval training. They did 3 different types of aerobic training, exercise, and they found that the liver steatosis was reduced in all groups. They also compared resistance training with aerobic in NASH patients, and they found that there was really no difference between the 2 groups. So it gives us a wide scope of what we can recommend for our patients based on compliance, what we're going to get out of them. And of course, we all know that if we can just get a patient exercising, they will build on that as they start feeling better. I actually think it's good to have a combination of aerobic and resistance. And as we age, if you read the research, it says that the older we get, the more important the resistance comes as opposed to aerobic because we need to keep that muscle mass up to avoid the sarcopenia. So what's the phytotherapy for NAFLD? This is, for me, the part I love. This is where my passion is. But of course, we have to understand everything I've spoken about up to this point so we know what herbs to use and what we're wanting out of those herbs. This was a systemic review and meta-analysis published just this year, and they found that there was a statistically significant improvement in transaminases compared to placebo, irrespective of weight loss. But of course, we're going to be doing a whole range of other things that increase weight loss, which give us even better benefits. Another systemic review meta-analysis found that silymarin, which is milk thistle, reduced AST and ALT better than controls and better than interventions like metformin and Actos, which is a TZD. So the silymarin performed better than the drugs that are very commonly used to treat metabolic disorders. We know that if we can improve the level of these transaminases, we're actually improving liver function and we're reducing the progression of NAFLD to other more serious conditions. So the additional benefits for milk thistle, if you look at them, they really all relate to what we're talking about. They can help reduce iron and ferritin levels. We know that's a risk factor for NAFLD. It improves the bioavailability of berberine. And I think for metabolic disorders, we absolutely have to be using a good dose of berberine, and I'll talk about it in the context of NAFLD as well. And of course, it improves glycemic control and dyslipidemia, all of which we need to be doing in these patients. And the key actions, I like to talk about these because they're important. Milk thistle is what we call a hepatotropho-restorative drug. So it helps to restore the function of liver tissue. So if you've got a lot of damage to liver tissue, milk thistle can help restore that. Of course, if it's got to the point of being cirrhotic tissue, you're not going to reverse that. But on the way there, we can reverse some of the damage that's done. And importantly, it's hepatoprotective. And that means that it will protect the liver from damage from anything, whether it's NAFLD, whether it's oxidative stress, whether it's a toxin or whether it's some sort of drugs the person might be taking, including excessive alcohol. It's antioxidant. Most of that antioxidant action is in the liver, and it's choleritic, which means that it helps with bile production and the quality of bile. And I think it's a must-have herb for any liver condition. Black cumin, Amanda talked about this. It's a fantastic herb for metabolic dysregulation. But when we look at the research, it's just coming up looking brilliant in the research for NAFLD as well. 2 grams a day, not a high dose. And they looked at inflammatory markers. At the conclusion of the study, compared to placebo, there was a statistically significant reduction of TNF-alpha, one of the major inflammatory mediators, a reduction in steatosis. There was a reduction in high-sensitivity CRP and NF-kappa B, but it wasn't statistically significant, but it was there. Another study, 2 grams a day again. And this is an interesting study. If we look at the graph at the beginning of the study, it went for 12 weeks, 70 participants. If we look at the beginning of this, where all patients were diagnosed with NAFLD, you can see none of them were normal, of course, because they all had NAFLD. And the blue is for the patients that were in the black cumin seed. Nigella sativa is black cumin. And the red relates to the people put in the placebo group. Let's look at what happened after 12 weeks. 57% of those patients no longer had NAFLD. Very few of them in the placebo group had that effect. So for me, that's astounding, just after 12 weeks. We could use black cumin alone and get fantastic results, but of course we won't do that because we can do all the other things that we know of with the diet and lifestyle, the exercise, and other herbs and nutrients as well. There was a decrease in body weight and BMI. There was a remarkable reduction in ALT and AST. There was a decrease in GGT, wasn't significantly statistically significant, but it was pretty close and it was still there. The researchers said black cumin improves biochemical and fatty liver changes in NAFLD patients, and its use in early stages of NAFLD is recommended to prevent life-threatening complications. I think don't even wait till they've got early stages of NAFLD. In any patient that is even overweight, particularly if they continue gaining a little bit of weight, get them on black cumin before they become obese, before they develop metabolic syndrome, and definitely before they develop NAFLD. There's a whole lot of additional benefits. I'm not going to go through these. The ones in yellow relate directly to what I'm talking about with NAFLD. Turmeric. You can use the high curcumin products. Systemic review and meta-analysis, significant reduction in liver enzymes, glucose, HOMA score, insulin, waist circumference, etc. There was a positive effect on visceral fat and abdominal obesity, reduced BMI, and reduced waist circumference. So, just looking at this, we've got 3 herbs that I think you have to be using in these patients. And you probably, if they've got metabolic syndrome, you're already going to be thinking about them from that point of view. Researchers say it's a promising treatment for NAFLD, reducing the enzymes and NAFLD severity. If we look at berberine, this was a study where they had 3 groups that went for 16 weeks. They did lifestyle alone, and that lifestyle was, all they did was they asked the participants to limit calorie intake just by subtracting 500 kilocalories from their calorie intake daily, and for them to do 150 minutes of medium intensity aerobic exercise per week. The second group was berberine plus lifestyle. They used 500 milligrams of berberine three times a day and half an hour before meals. And then there was a group that were given a TZD. So what happened? The berberine plus lifestyle, compared to lifestyle alone, significantly higher reductions in liver fat, glucose, triglycerides, and cholesterol. So this shows us the power of not only doing the lifestyle changes, but adding a herb or herbs to that. When we compare berberine and lifestyle with against the TZD, similar reduction in hepatic fat content and blood glucose, but berberine and lifestyle had the added benefit of weight loss. So I'm not sure about you, but if it was me and I had the choice of a TZD, which we know can cause cardiac toxicity, and taking a herb and adjusting my lifestyle, I know what I'd be choosing. I'd be choosing the herb and the lifestyle. Further analysis of this study showed that there was a substantial change in the serum lipid profile compared to the lifestyle alone. And what we see there is altered circulating ceramides, so lower levels of ceramides, which which they think underlies the improvement. Ceramides are bioactive lipids, and we know that they can play a role in the pathogenesis of NAFLD and the progression onto fibrosis, etc. If we look at the additional actions, I'm not going to go through these again, many of them relate to metabolic disorders. Globe artichoke is a herb that we've used traditionally for liver problems, and it helps for bile production in the liver and make sure that bile is of a good level of constituents, good composition, healthy composition. This was just a pilot study, and they found that there was ultrasound improvements on hepatic vein flow, reduced portal vein diameter and liver size. There was a reduction in bilirubin and liver enzymes, a change in the AST-ALT ratio, and improvements in the dyslipidemia. Another study showing improvements in dyslipidemia with globe artichoke. Cinnamon, Amanda's already talked about this. This was given along with dietary and physical and activity, exercise advice as well. Compared to placebo, there was a reduction in liver enzymes, high sensitivity CRP, HOMA-IR score, and the dyslipidemia that we see. So it's not only good for metabolic disorders, it's also good in the context of NAFLD, even if there's not those metabolic disorders. And how do we reduce oxidative stress? We absolutely have to be doing this, because if you cast your mind back to near the beginning, it is the major driver of NAFLD. It's easy. We support NRF2, and we can do that because we have a whole range of herbs, phytonutrients, many of which are foods that can support NRF2. So that's very easy to do in clinical practice. We need to support microcirculation because microvascular dysfunction is a feature in the early stages of NAFLD. It also is involved in the progression of NAFLD to more serious conditions. And if you start researching any chronic disease, you will see that they're finding that microvascular dysfunction is a feature in the early stages. And this applies to osteoporosis, osteoarthritis, a whole range of conditions that you may not be thinking about microvascular damage, but it happens early on. So I personally think anyone over 50 should be taking herbs and or foods to support healthy microcirculation because its function does decline with age. And that's why many of these conditions are diseases of aging. So how can we support microcirculation? My favourite combination is gotcha cola, ginkgo, and grapeseed. And there is evidence to show that gotcha cola and ginkgo is very beneficial for reducing hepatic steatosis. And gotcha cola has the added benefit of being anti-fibrotic, which means it reduces the incidence of fibrosis and it aids healing. So fantastic combination of herbs to be using in patients with NAFLD or anywhere where we want to be supporting microcirculation. And of course, there's a whole range of other herbs that we can use. Again, you'll see some of them are foods, green tea, garlic. We don't have bilberry as a food, but any of the berries, dark berries, will do it. And Kerry Bones put together a 5-point microcirculation nutrient plan, which is in the appendix of this presentation, and he will also be talking about it when he talks about type 2 diabetes. So I think after that, I hope you feel well armed to tackle this problem in NAFLD because we do have a lot to be able to help our patients. So we'll finish with a case history. Like Amanda's, it's a fairly extreme case. 55-year-old female, lifelong battle with weight, especially as an adult, and she had that history of yo-yo dieting. And we know what happens there. People lose weight, they put it back on plus more usually. She suffered from anxiety and her doctor had referred her to a psychologist. I've given her weight and all her measurements and everything a bit later on when we look at how the treatment worked. She tends towards high blood pressure. She was a very obese woman and she says, but I eat very little. Maybe, maybe not. But she frequently, when I went through her diet in great detail with her, she frequently had pre-packaged sauces and powdered flavourings. They've got to go. She ate a lot of dried fruit, got to go, high concentration of sugar, but also sulfites in the curing process. 4 cups of coffee a day, each with 1/3 of a cup of full cream milk. She had a cup of Milo every night. Now, I know you don't have Milo in the United States, but it's a chocolate drink loaded with sugar. And in my experience, anyone that has Milo doesn't put a teaspoon in the cup. I've watched my grandchildren, they half fill the cup with Milo and then they put the milk on top of it. So who knows how much Milo she was getting in this cup per night? A lot of sugar. And 5 glasses of shop-bought orange juice each evening. Thank goodness she didn't have any alcohol. So you can guess what dietary changes I might have made here. She did no exercise at all. So for the assessment tools, I did the fatty liver index, 99.56. Anything above 60 is fatty liver. This is worrying. When I did the 2 different fibrosis scores, she was in the intermediate for one, and the FIB4 I think is a little bit more sensitive. That showed that she didn't have advanced fibrosis, but I just assumed she could well have early stage fibrosis. So what did I do for her? Dietary changes. Avoid pre-packaged foods, no takeout food. That was the other thing. She says she doesn't eat very much, but a lot of what she did eat, she had 2 teenage children, and quite honestly, she seemed to be a slave to the whole family. And so the children want to take out food. And what would that be? It would be McDonald's, it would be KFC or something. And I would say, but you don't have to eat that. You can do your own food. Oh no, it's just easier, and then we're all having it together. No Milo, no orange juice, etc. Increased vegetables. I gave her the information about the Mediterranean, the portfolio diet, and got her to try and go with that. But to keep it simple, I said, and keep the carbohydrates down, I said just 1 serve daily of high carbohydrate foods. So those high carbohydrate foods are bread, grains, cereals, potatoes, sweet potatoes, corn, etc. And 1 serve is a cupped palm of cooked food, or if you're talking about bread, it's 2 slices. But try to avoid any of these foods 2 days a week. And I said to substitute the white bread with whole grain sourdough and the white rice with brown rice or quinoa. Incidentally, I know this patient was referred to me by another practitioner, so I know that her compliance over the years has not been very good. So I tried to keep it fairly simple. Exercise, I kept it simple. She was grossly overweight, no energy. I said walk around your yard once every morning and once every afternoon, and that wasn't a very big walk. And then for week 2, increase it to 2 circuits twice daily. Then week 3, we went to walk the length of your street morning and afternoon, and then walk around the block twice daily. And that took her about 30 minutes. So over the time from when we started to when I wrote this presentation, she had gradually built up the distance she was walking in that 30 minutes, which is very good. And it was no mean feat for her. Self-care, as I said, she seemed to be a slave to the family. She never had time for herself. I said, you must make an appointment with the psychologist. And I said, you must sometimes do absolutely nothing. You have to have quiet time. I kept it easy, at least 15 minutes twice a day. And I also discussed good sleep hygiene because she did have trouble sleeping sometimes, and just the reducing chemicals around the house as well. So to start with, the first 6 weeks, we did the GI balance protocol, and I've got that in the appendix. And I also talk about it in the protocol section that Amanda and I are doing later. Plus, I gave her bioavailable curcumin and milk thistle. Then from week 7, I gave her a whole range of things. We kept the milk thistle, did berberine. I gave the combination of bitter melon, black cumin, cinnamon, fenugreek. We kept the bioavailable curcumin. I gave the coleus to help with weight loss, but also to deal with the tend towards hypertension, because it's a great herb for hypertension. I gave her kava, 1 on rising to deal with, she had, often felt a bit anxious in the mornings, and then 2 before bed for the anxiety and sleep. And we stopped that at about week 14 because both of those things were much, much better. She had also been seeing the psychologist. I gave her a liquid formulation of ashwagandha, rehmannia, gotcha cola to have 5 ml twice a day. So we've got the adaptogenic and adrenal activity there that we need to support the stress response and improve energy, and the gotcha cola as an anti-fibrotic herb, because I suspect she did have early stage fibrosis, and a healing herb, and of course to support a healthy microcirculation. And her vitamin D was low, so I gave her 3,000 IU daily in a single dose, and over time we reduced that to 1,000 because her vitamin D levels had come up. So here's the result. She started at 287 pounds. Her BMI was 51. Astounding. High blood glucose, some of her liver enzymes weren't too bad, but certainly ALT was very high, and I've already talked about the fatty liver index. So let's, we tested at 3 months, 8 months, and 12 months, and it was a real battle to get her to go to the doctor and get blood tests. There is another slide as well following on from this one with other parameters, and she never went back to get another CT scan for fatty liver. So look at the BMI after 12 months, 35 as opposed to 51. She's still got quite a way to go, but she's done really well. Fasting blood glucose, on the high optimal, but at least it's in there now. The ALT, again, high optimal range, but it's still there. GGT had come down, and look at the fatty liver index score now, 12.75. So we can say, based on that, she no longer has fatty liver. I would like to also see another ultrasound to determine whether she's got the fatty liver. And the fibrosis score has also come down. So we can rule out fibrosis at this stage. Other things that have improved as well, and certainly her vitamin D3 has come up into the normal range. So very good results over 12 months, and it's a long period of time, and she's still got a long way to go. But actually, I'm very astounded that this patient actually got there, because when I first started seeing her, she was one of these patients that had every excuse under the sun why she can't exercise, why she can't really change her diet. But she did come around, and I think she came around because she had been battling with this for so long and she was fed up with it. But also, I just started slowly, a little bit of exercise, you know, fairly significant changes to the diet, and she didn't take them all on board straight away, but over time she did. And what I find with patients is that they will do that. You just have to get them feeling a little bit better, and then they'll start doing what you want. So thank you very much for your attention. And also I would like to acknowledge Professor Kerry Bone and Amanda Williams for their input into this presentation. And Amanda and I will be doing the protocol session next, and then we'll be able to go to question time. So thank you very much for your attention.